Good afternoon, everyone, and thanks for tuning in. I am Michelle Owens, and I am happy to share with you our experience in Mississippi, COVID-19 challenges and lessons learned. So first off, I don't have any relevant financial disclosures. That being said, I am a mother of three, so I'm always interested in advancing that. If there's anybody who wants to talk to me after this during the Q&A, I'll be more than happy to entertain those. And this is just a quick little outline so you have an idea of where we're going to be going through the course of the talk. We'll start with just a general overview of coronavirus and COVID-19. I'm sure there are many of you who will know a lot of that information. And then I broke it up into the antepartum, the intrapartum, and the postpartum information. And as we go through the slide deck, you'll notice that some things are highlighted in red. And so I highlighted those lessons learned in red so that you would be aware of what they were. And then we will kind of finish up with a little bit of what remains. So first of all, what is coronavirus? Well, it's a large family of viruses that can infect birds and mammals, including humans. You may have heard about coronaviruses because they cause mild to moderate upper respiratory tract infections generally. So when we think of the common cold, there are several types of coronaviruses that cause the common cold. But these viruses have also been the causative agents behind several pandemics and epidemics over the past couple of decades. Many of you will remember the SARS pandemic in the early 2000s. That was severe acute respiratory syndrome. And then also in the Middle East, there was Middle Eastern respiratory syndrome, or MERS, which was an outbreak in Korea, I believe, in 2015. So these are viruses that have been around for a while as a family, but there's been a new member that has been birthed, so to speak. And this newly identified coronavirus, which is SARS-CoV-2, is the actual virus that has been behind this worldwide pandemic that causes this respiratory illness that we now call COVID-19. So the novel coronavirus, as we know, can be spread from person to person. There is not a vaccine at this time. So we've really focused our attention on the preventive side. So how do we prevent the spread of COVID? The things that you all have probably been doing and heard ad nauseum over the course of the past couple of months, which includes, of course, frequent hand washing, soap and water, best thing, at least 20 seconds every time, sing happy birthday twice, covering your coughs, sneezing into your elbow, those kinds of things, trying to minimize your hands to your face. If you are ill, this is one of the times where you really need to stay home if you're sick. Social distancing, which I think we're all probably a little tired of now, but it's working, so stick with it. And wearing a face covering, whether a cloth mask or a surgical mask, if social distancing is not possible. And all of those things are at the core of the preventive piece, which right now is really the best thing that we have against this virus. So now we're going to move on and talk about COVID-19 and pregnancy. And I'm going to give you a little background about pregnancy. And this was initially thought to be one of the challenges at the wake of this outbreak back in the early part of this year, as we were starting to see this spread across the world. Because pregnancy is a state of partial immune suppression, and that kind of makes sense, right? Because half a baby is not from mom. So you have to kind of dampen the immune system in order to allow for a baby to grow. So because of this partial immune suppression or immunocompromise, pregnant women tend to be more vulnerable to viral infections in general. And many of you who may have been pregnant or who are involved in the care of pregnant women know that we screen for a multiplicity of viral illnesses at the onset of pregnancy. And there are also times throughout the course of pregnancy where a woman may be exposed to a certain viral illness, and it makes us have a heightened sense of concern. So this was a big concern for those of us who were taking care of pregnant women, because in many of the other respiratory type virus infections that we've seen in the past, pregnant women have performed particularly poorly. For example, pregnant women who get influenza, the fatality rate is much higher than we expect to see in non-pregnant women. And also with many other illnesses, what pregnant women, if they are affected, tend to do worse. So because this has a primary respiratory manifestation, we were specifically concerned about whether or not this was going to be a harder disease for pregnant women, or if pregnancy was going to automatically mean that women were going to have a worse version of the disease than if they were in the non-pregnant state. Remember, I said red is one of those lessons that we've learned. And I say that keeping in mind that we are still learning every day. This is a new virus. A year ago, it wasn't known to us. And so we are still figuring out how this virus performs and what the truth really is. But the current available data now suggests that pregnant women appear to have the same risk of COVID-19 as non-pregnant adults. So Dr. Owens, what does that mean? That basically means that pregnant women have most of them have mild disease. We are seeing a lot of asymptomatic carriers in our pregnant population. So if you're a pregnant woman and you do get COVID-19, it doesn't necessarily mean that you're going to end up in an intensive care unit and on a ventilator. It does not mean, however, that pregnant women shouldn't take extreme precautions in order to prevent infections. Because again, the best way to have a healthy pregnancy is to have a healthy mom. So ideally, we would like for none of our patients to become infected. But if they do, what we know so far is that women tend not to have severe disease any more than the general population. We've also noticed, as I mentioned, a higher rate of asymptomatic carriers. And these are women who may have come into the hospital for a variety of different things. Keep in mind, pregnancy is still continuing even though COVID is happening. So while many different areas around the country and around the world have experienced a decrease, especially in medical practice and medical flow, for those of us in the obstetrical world, that hasn't really been as marked. We've changed how we have functioned a little bit, but for the most part, we've still continued to provide care for women. You don't stop needing prenatal care just because you're in the middle of a pandemic. And so one of the things that we've noticed, specifically at the University of Mississippi Medical Center, as we have instituted a policy of testing all women who come into labor and delivery, is that there are high numbers of asymptomatic carriers. And that kind of makes sense and is in line with what we see in the general population, why the vast majority of our patients are young and healthy. And so if they do contract the virus, they aren't people who become highly ill, unless, of course, they fall into one of the other high-risk categories. Again, red means lesson learned. A very telling thing has been the amplification of racial and ethnic disparities when it comes to those who are infected. So it's not about the severity of disease as much as it is about the fact that we were seeing in our patient population a huge disparity in those women who were testing positive based on racial and ethnic lines. So for example, we saw much higher rates in our Hispanic populations, much higher rates in our African American populations than in our Caucasian populations. And so what this allowed us to do was to target educationally through the utilization and partnership with community partners, information to our patients and to their communities so that they could make sure that they were doing everything they could to protect themselves. Now, we understand that there are some unique socioeconomic issues that were in play that may preclude people from being able to optimally protect themselves. For example, many people don't have the luxury of being able to socially distance within their home or to isolate themselves. The way that they work may not be conducive to a 6-foot distance away from the next person and those kinds of things. But it was really important from our perspective and from a public health perspective that these places where we were seeing higher rates of infection actually got the information that they needed in order to be able to do the best that they could within the circumstances that they were giving. Additionally was the impact of testing. And this was really important because if patients who were screened coming into the hospital didn't have any positive answers to the screening questions and they didn't have a temperature or symptoms at the time of their presentation, those people had been presumed negative and were treated as being presumed negative. But in some instances, we would see that those people might develop a fever in the postpartum period or during the time that they were in the hospital or during the time of delivery, and then they would be tested and found to be positive. And there was the issue of tracking through the healthcare system. Where had they been? What had they experienced? And so it made it very difficult to try to minimize the spread, not only for the healthcare team, but for the patient and anybody else who might have been with her as a support person. I think the greatest impact has been that when we identify those asymptomatic carriers, those people are armed with information, and then they can do the best that they can for their families and for their babies by using that information and taking the necessary precautions going forward. Because once you have been assured that you're positive, that becomes a reality for you that you then can deal with. There have also been some unintended consequences, and I think there are all the time. Fear is a very potent motivator. And I think initially, as we were responding to the pandemic, there was a lot of uncertainty, there was a lot of loss of control, and there was a lot of anxiety and fear. And that fear was not something that pregnant women were immune to. And as a result, we saw that there were women who were afraid to interface with the healthcare system, whether that was their routine visits or even women who otherwise would not have felt uncomfortable going to the hospital in order to have their baby were concerned about whether or not that might create undue exposure for them. So we saw a shift away from that routine accessing of medical care to people being a little bit more contained and staying in their homes and being more fearful. We as a medical community had to change the way that we deliver healthcare in order to provide for that and to account for that. We also had to work to try not to create unnecessary barriers for transportation and other things for our patients. So many of us went to telehealth and other innovative models of healthcare delivery in order to be able to address that. The next is the stigma that's associated with infection. And there were a remarkable number of women who have shared with me their concern upon finding that they were positive, or even a fear of learning or knowing that they were positive. They were concerned about that information being spread and how it might affect them in their communities or in their homes or with their families. And it even led some women to refuse to be tested because they figured, well, what I don't know won't hurt me, or I'd rather not know. At least that way, if I don't know, then I could be presumed negative and continue on with normalcy and not have to address the issues or the challenges related to what that would mean if I was positive. The other issue was isolation. And so we've talked a little bit about how people had to stay home and other things. For some individuals, staying home was a bit of an inconvenience, but it was still manageable. But for a lot of people, that isolation during delivery and in the postpartum period was really difficult. And there was a while for many healthcare institutions where it was hard for us to know what was the best thing to do for women as far as minimizing risk, trying to control our limited PPE and other things, and to still be able to provide women with the benefit of what we know is that having a lay person or a support person during this important time is really significant. And so there have been limitations that have been very fluid and have varied widely depending on the areas where these women delivered about visitation and whether or not women would be isolated from their babies or isolated from their families. I don't know that we've gotten that exactly perfect, or at least I know that it's probably not been ideal for everyone. And I think that that's an area that is still continuing to evolve as we are kind of trying to ride out the wave of the ebb and flow of COVID-19 and these peaks in numbers and then decreases in numbers. So there will probably be more to come there. Another thing that we learned, which was necessary and also very good, is that extreme precautions were necessary in order to limit the spread of the virus and to ensure protection for both our patients and for the healthcare team. And when I say extreme precautions, that's from a personal level, as far as what we all had to do in our vigilance for trying to reduce the spread of disease, changing things about how we wash down things and help to make our healthcare environment the cleanest that it could possibly be. But also from a procedural standpoint, how do we handle when a patient who has COVID comes into the facility, and being able to work that out once, like from the moment that they come in all the way through to the very end, was an interesting process, but it was necessary. And I think our hospitals and our healthcare environment is better now because we are able to accommodate. So this was something that didn't exist before. Now we have it. And we saw the healthcare environment have to change in order to make those accommodations, not only to protect the people who worked within our system, but also to protect our patients and to be able to give them that assurance that they could come in without fear of leaving with something that they didn't come with. And so I just throw this picture in. This is from a night on call where we had several COVID positive patients, and it just shows I used to not do deliveries like this. But this was not a delivery that was happening in an OR, but this was actually a delivery that was happening in one of our negative pressure rooms. And this was me fully in my full PPE attire, getting ready to go do a delivery, and also still trying to have a little fun because it was in probably about 4:30 in the morning when this picture was taken. So it might have been a little delirium included in that as well. So a little bit about the medical complications, and these have been some really interesting things. So there have been some lab findings that have been associated with COVID-19 that are a little bit out of the norm. A lot of these people have problems with very high glucoses, also elevations in D-dimer. In pregnancy, we haven't really worried about that so much because we know that D-dimers can be elevated because of pregnancy alone, but that the elevation or really high D-dimers in patients who are not pregnant is also another finding. High ferritin levels have also been associated with the diagnosis, in addition, of course, to pneumonia or these pulmonary infiltrates that can be seen on imaging. Oh, and also, I almost forgot, another thing that we see pretty commonly is an increase or elevation in liver function tests. And so I mention those because that there's some overlap in pregnancy with some of the things that we typically see. As I mentioned, the D-dimer is one of them. One of the things we don't typically see in pregnancy is an elevation in liver function tests. And so for most of us who take care of pregnant women, if we see pregnant women who have elevated liver function tests, then we start thinking that there's some other process that's going on. And so there's been quite a bit of overlap or a concern that women who have had COVID-19 might have been either misdiagnosed with preeclampsia, or that preeclampsia rates have been higher in this group. And I don't know that we've really teased that out very well, but we do know that liver function tests tend to be higher in those women with COVID-19. And so sometimes in pregnancy, if you might just have a patient who has elevated liver function tests, and then we start watching and maybe she has an elevated blood pressure here or there, that may lead to a different diagnosis. And there's not been a large enough group of these patients who've been studied or followed. So it's just something to be mindful of as you are caring for women who might have either COVID-19 and be pregnant, or in whom you may see unexplained elevations in liver function tests. It may be worth investigating, or at least keep in your mind that this is a possibility, again, because many of these women can be asymptomatic. With respect to clotting issues and anticoagulation, if you read about the clinical findings or scenarios for most of the people who actually have COVID-19 who are not pregnant, many of them have problems with clotting. Whether it's DVTs or PEs, it's pretty well accepted that many of these people have problems with that, and a lot of times are offered or are initiated on anticoagulation. For our pregnant women, they're already at an increased risk for thromboembolic disease or for clotting. And so since we know that pregnancy is a state that increases your risk for clotting, in these women who have COVID-19 who are hospitalized, we have been instituting anticoagulation. That has not been continued once their symptoms resolve and they are over their infection, but it is something to also remember, and it's something we get a lot of questions about. So with respect to treatment, it's a virus. And so there's no specific antiviral treatment that we have that's recommended for COVID-19. It's really just supportive treatment to give your own body, or give the body, an opportunity to fight off or control the virus. There are some things that have been instituted in this process, like proning, which is basically laying on the belly. And pregnant women can do this very early in pregnancy. Of course, later in pregnancy, it can be an issue, but proning has been shown to make things better in some instances. And so we have allowed pregnant women to prone where it was feasible based on gestational age. The other thing to consider is body habitus, because that may also preclude patients from being able to have true benefits from proning. So it's something to consider with critical care colleagues. Pregnancy doesn't rule out the opportunity for proning to take place, but it does need to be considered in the clinical context. And of course, there's remdesivir. And I put that in red as a lesson learned because I think that's something that we are still learning. Remdesivir has been used experimentally in patients who have COVID-19, both in pregnant and non-pregnant. And it has been shown thus far as of a publication that was published in the New England Journal of Medicine in May to shorten the duration of recovery in those people who have who are hospitalized. So it's just something to consider. The problem is that, of course, that there's no randomized controlled trial that's ever looked at pregnant women. And so the data that we have for pregnant women is very limited. However, there is some data in pregnancy, and that comes from mostly from the Ebola outbreak. But that information seems very positive. It does not, there's no teratogenic effects that have been shown in animal studies or in the humans that have received the drug. And so as long as the risks outweigh the benefits, it is recommended, its use would be considered acceptable. It is a nucleoside ribonucleic acid or RNA polymerase inhibitor, which is just, it tells you the mechanism that the antiviral works. So we have been incorporating this into some of the protocols in conjunction with our critical care colleagues at the University of Mississippi Medical Center. Our results, though very small, have been positive. We haven't had any negative effects. And so we're very excited to see what this looks like as there are more and more people around the country who are considering this as an option during this difficult time. So getting to the postpartum period, we're going to talk about breastfeeding benefits. And if you'll notice, breastfeeding benefits is in red. And that's not really a lesson learned because we always knew that breastfeeding was best. However, the fact that the benefits are still there, even in COVID-19, I think has been a lesson and has been an incredible win for us during this very difficult time. It's been one of the things that hasn't shaken our foundation. It hasn't changed what we already know. So the medical benefits, of course, still continue, but it hasn't been without its challenges. And the challenges have been, what do you do when you have an infected mom and a brand new baby? We don't have any evidence that supports the fact that vertical transmission for COVID-19 is something that happens routinely. So when you have a new healthy baby and a mom who's very much excited and interested in breastfeeding, but who's COVID positive, how do we deal with that? And how do we, breastfeeding by nature helps with bonding and it brings mother and baby together. And then you have this issue where decreasing transmission is kind of predicated upon separation. And so we've had to really kind of work through how to do that. And it's good that there are ways that women can continue to breastfeed, even if they're positive. And while the social distancing is preferred, if it's not possible, then of course, mom with hand hygiene, a mask, even with pumping or expressing milk, and then having a non-infected person feed the baby. Or if she feeds the baby, then just making sure that she, uses gloves, has a mask, and goes through the normal preventive measures. That's still something that we can do. The next issue, of course, is for those women who for a short period of time may not be able to breastfeed immediately, and the issue of relactation, and continuing to encourage that if there's a short period of time, say for example that a mom's been on remdesivir and is transitioning, there's data to suggest that there may be small amounts of remdesivir in breast milk. So if you needed to have that time to pass for mom to be able to continue to breastfeed, how we can continue to keep that going at a time when stimulation is really what is going to set the course for how the body's going to respond. The other thing that I think is really important, and we haven't talked a lot about when it comes to breastfeeding, is the socioeconomic challenges. And I say that because socioeconomically, we'd always say all these great things about the health of the baby and why moms should continue to breastfeed and the good bonding for the family and all these other things. And then we go, oh, and by the way, it's free, which is great because it is. But I think that probably has become even more important. I think at times when the fact that it was free might not have resonated to people. In these times now, when unemployment is highest and people are struggling to make it and to make ends meet, when you are socially distanced or you're under stay-at-home orders and you don't have access to formula the same way, if you were a person who was insured and you've lost your insurance and things are different and difficult for you, I think that those things still matter. And I believe that, being able to address those and to present those to patients, not really necessarily to incentivize them, but just to say, hey, this is one area of your life that doesn't have to be negatively impacted by the circumstances that we find ourselves in. And this is actually a way that you can champion over or be a champion over the circumstances as it pertains to your family, and at least for the food security for your baby. So that was another thing that I thought was really worth bringing out, and that could actually be something that could help bring a little bit more peace in these anxious and uncertain times. So now, lastly, as I mentioned, it's what remains. I think now what we're doing is figuring out what we can do better. We are still continuing to learn. Testing now is becoming a little bit more fluid, hopefully a lot more available. And I think that with that, we will also know more. We will also be challenged more. People are going to be out and about more. And so we are still going to have, I think, times when things are better and times when things may be worse. And so we're going to have to figure out how to ride out those waves, and how our lives going forward are going to need to be modified even further or changed in order to make sure that until we have a better way to address this issue, that we can continue to try to keep one another safe. Of course, testing dilemmas are there. There are questions about serology, antibody testing, and all other kinds of novel tests that are coming, and the significance of those tests, and whether or not they're even beneficial. So I think there will definitely be more to come. But I think that we can take the good things that we already have learned and know and put them into good use for the future. So lastly, most of you who know me, who've ever heard one of my talks, I always throw a picture of my kids in because they are really my why. And instead of throwing in a picture of my children, what I did decide to do was take these two posters that my son made as he was standing outside holding up the signs for healthcare workers to help encourage people during this coronavirus. And I just wanted you to know, for those of you who are healthcare helpers, or if you're caring for people, or if you're just one of those individuals, we are all heroes in our own right and respect. And thank you so much for your time and attention.
I'm Dr. Anita Henderson. I'm a pediatrician in Hattiesburg, Mississippi. I work at the Pediatric Clinic, which is part of Hattiesburg Clinic, and I'm also on staff at Forest General Hospital. I am currently the president-elect for the Mississippi chapter of the American Academy of Pediatrics, and I am also the physician champion for Forest General when we became baby-friendly through the Baby-Friendly Hospital Initiative several years ago. So Forest General Hospital was actually the first hospital in the state to become baby-friendly, and we are actually in our reaccreditation, redesignation phase right now. So today, I just wanted to talk with y'all a few minutes about some hospital changes, clinic changes due to COVID-19, highlight some of the positives and negatives we've heard from maternal interviews and surveys, discuss a few of the big questions that we as pediatricians are getting from our moms after delivery and after discharge from the hospital, touch on some potential short-term and long-term impacts of COVID-19 on babies. I wanted to mention well baby visits. We are missing those right now, and there are some concerning consequences, and a quick update on the Mississippi Mother's Milk Bank. So Mississippi had its first case of COVID-19 on March 11th. That actually was at Forest General Hospital here in Hattiesburg, Mississippi. And as you can see from this graph, that was put out by the Mississippi Department of Health on June the 12th. If you pay attention to the yellow line, that gives you a 5-day average of our COVID cases. During the month of April, we hovered in the 200 range. During May, we bumped up to 300, and actually on June 12th, we've hit a spike of about 364 new cases per day. The other interesting lines right there, the pink are the ICU patients, which are hovering in the 150 to 160 range, and the purple is the patients on the ventilator. So that's hovering right around 100. So you can see from this graph that we are having more and more cases, but the numbers in the ICU and on the ventilator seem to be sort of stable. And one of the interesting facts from Dr. Dobbs was that a high number of these new cases are actually in the 18 to 29-year-old range, the 30 to 39-year-old range, and the 40 to 49-year-old range. So you can see the cases are in the younger people. However, in this red bar, those are the fatality rates. So the elderly population obviously have higher case fatality rates. However, we're seeing more and more cases in the younger population. As far as the newborn care changes in the hospital, I think we've already gone over a good bit of COVID and person under investigation policies in some prior webinars. At Forest General Hospital, initially our visitor policy mandated that only one person could be in attendance for labor. And our updated policy, however, says we can have, a mom can have one person for the entire duration of her stay. In the NICU and for peds patients, initially we also just had one caregiver, and now we are allowing two people, and it has to be the same two people. The entire hospital says that all visitors must be over the age of 18. They get temperature checks on arrival along with screening questions. And I will say that the nurses and our staff actually really like these changes, and I'll highlight the reasons why. And one other thing I would highlight is that the majority of the new cases in Mississippi, and particularly in the Hattiesburg area, are community acquired or are outbreak related, not hospital related. What that means to us is that our hospitals and our clinics are doing a really good job with infection control, with our masks, with our PPE, with our glove policy, and screening our staff prior to arrival. So the outbreaks are in the community, within families, within groups, as opposed to the hospital or clinic setting. So over the last few weeks, I've been asking all of my moms when they come in for their 2-day and 2-week vet visits about their experiences at the hospital. So a few of the negative comments that I've gotten, one mom felt, particularly back in March when this was just starting up, felt like she got out a little too quickly. She was pushed out a little too quickly, right around that 24-hour mark where she might have preferred to stay a little bit longer. Obviously, siblings cannot visit. Some moms are having a hard time keeping up with policy changes. And I would remind everyone at their hospital to make sure their policy is on their hospital website so that moms can look and see what the visitation policy is. I had one mom who actually investigated several different hospitals in the area, and she was considering switching to a different hospital because initially she thought she was not going to be able to have a labor support person. So moms are reading the information that is put out there on hospital websites, so I would encourage you all to make sure that's up to date. There are many, many more positives that I've noted. Several moms have said they seem to have more time to bond with the baby without having any visitors. The pace seems to be a little bit slower. It's quieter. They actually are coming out of the hospital more rested because they're able to take naps, not worry about family coming. One mom said she felt much less stressed. And one mom even said she wishes that this had been the policy with all of her babies because she actually wouldn't have gotten her tubes tied at that visit. So I feel like in general, the vast majority of the moms are feeling actually that the no visitor policy seems to be beneficial. I talked with one of our lactation nurses to ask her about some observations, and she noted that some moms actually seem more interested in breastfeeding. They are, in some cases, more interested in exclusively nursing, especially during that time in April when things were kind of in the height of the lockdown. They seem to be retaining their information better. They don't have as many distractions. They don't have children or visitors, so they are actually listening And the moms and some of the dads have told me they're actually able to retain some of that teaching. The nurses seem to have more time to teach. Moms seem to be getting more rest, and several moms have mentioned the immune benefits of breastfeeding and have been interested in breastfeeding in order to prevent possible illnesses other than COVID, which most moms haven't been exposed to, but they are very interested in the immune benefits. As far as the outpatient clinic goes, again, our first case was March 11th. After that, we at my clinic started doing our 2-day postpartum visits with our babies via telemedicine because we really didn't want moms coming in and exposing their babies. Those went really pretty well. Moms seemed to love them, but we found that, in some situations it was obviously difficult to gauge weight. We seemed to have a little trouble looking at that jaundice and looking at their skin. We could ask them questions about stooling and nursing, but when we got a good supply of PPE, we went on back to our seeing all our 2 days in person in April. In our clinic at Hattiesburg Clinic, the pediatric clinic, we only allow one parent or guardian per patient, but we have made exceptions with our new moms for our two-day visit and our 2-week visits, because we know moms may need more help. They may have had C-sections, so we do allow 2 people to bring those new babies in. All adults and children must wear a mask. If they don't bring their own mask, we provide one for them. We have our patients and parents wait in their car until a room is ready, and then our nurse calls them, meets them right at the front, and brings them straight to a room. I have noticed an increased number of telemedicine visits, particularly for things like fussy babies, gas, colic, spitting, and that's a great resource to use a telemedicine visit for. And so we've been encouraging those for some of those more mild illnesses. One thing moms have mentioned is they do seem a little more isolated. They are unable to access their traditional support systems, such as grandparents, family, friends, and relatives. So we definitely encourage them to keep in touch with family via FaceTime or Skype, and try to continue to rely on those support systems. So what are parents asking us about? What are moms worried about? One thing that they will ask is if they happen to get COVID or test positive for COVID right before delivery or shortly thereafter, what's going to happen to their baby? And obviously each hospital has its own COVID policy for positive moms, and those policies are changing day by day, week by week. But I was encouraged to see recently on one of the polls that most hospitals are utilizing some shared decision making because we do not want those moms and babies separated unnecessarily. Moms are concerned that if they test positive, is their baby going to be taken away? And obviously we don't want that separation when in doubt. Giving them the risks versus the benefits, depending on how sick a mom might be, obviously seems to be the best way to go, taking it on a case-by-case basis. Actually, at Force General, we've only had a few positive moms. We actually had 2 this past weekend and 1 that was a 27-weeker a while back. So we have not had a very large number of COVID positive moms. Moms want to know when their baby can see their grandparents and their family members. And that's always a question, but even now with COVID, they want to know when that's safe. And that's going to be up to you as a pediatrician or a healthcare provider, and in conjunction with discussing that with their family. But certainly we want babies to get their 2-week checkups and their 2-month set of vaccinations before seeing anyone. And after that, it's going to depend on that particular situation. They want to know how we as healthcare providers are going to keep their babies safe when they come to our clinic for checkups. And again, we do a lot of hand sanitizing, hand washing, keep our rooms clean, and we keep our patients in their cars before we bring them into our clinics. We also ask a series of questions about fever and exposure prior to coming to a visit. So what about COVID-19 and newborns? There are a couple different cases out there of newborns who have passed away. One in South Africa, a 2-day-old died of COVID and the mom was positive. 3-day-old in Wales actually died after mother contracted COVID. And there are several other reports of newborns, but those reports are pretty rare. And it seems from the data we have so far that transmission is not through the birthing process or through breast milk, but a respiratory transmission. Another disease that's had some information lately and a lot of new data out there, a rare but severe disease, is the MIS-C, which is the multisystem inflammatory syndrome of children. It has also been called PIMS, which is the pediatric multisystem inflammatory syndrome. I also heard a webinar, since it's a Kawasaki-like disease, they refer to it as Kawa-COVID. However, the multisystem inflammatory syndrome of children, MIS-C, is the current approved World Health Organization nomenclature. It is a disease marked by inflammation. So the children will have elevated inflammatory markers such as SED rate, CRP, or a variety of inflammatory markers will be elevated. It is diagnosed by fever more than 24 hours, along with a severe illness that affects 2 or more systems. And some of those systems might be cardiac, renal, GI, hematologic, neurologic, or dermatologic. Again, it's very rare, but we're learning more and more about this, and it is a reportable disease. The Italian Journal of Pediatrics on April 29th published the largest report to date of over 2,000 cases of COVID-19 in children. The children seem to have less severe clinical symptoms. However, the children under the age of 1, that was the population with the highest number or the highest percent of severe or critical cases. So the bottom line from this series is that children seem to do pretty well. However, we do need to pay attention to the fact that children under the age of 1 seem to be at increased risk of severe respiratory failure compared to children over the age of 1. And again, we're getting more and more data. There seem to be new articles coming out on a daily basis with regards to children. Another thing we have noticed in a pediatric clinic is the decreased number of well baby visits. What happens when moms miss those wellness visits are they are missing postpartum depression screens. We do that on all of our checkups at 2 weeks, 2 months, 4 months, and 6 months. Those babies and children are missing out on developmental screens, physical exams, growth checks. We are also missing out on vaccination rates. There was a study in Michigan that showed that fewer than half of the infants under the age of 5 months were up to date on their vaccinations. We have had reports of increasing numbers of calls to domestic hotlines and increased reports of abuse and domestic violence. Parents are concerned about loss of jobs along with loss of health insurance. So it's important as pediatricians to make sure we do everything we can to keep our babies in for their well baby visits and work with their parents when necessary. Recently, there was a report that calls from Mississippi to the National Suicide Prevention Lifeline have increased 20% since the pandemic started. And so that information just highlights the fact that well baby visits are important, not just for vaccinations, but for depression screens. And sometimes that's the only touch that our parents and our babies will actually have with an outside clinic during this COVID. Many of my patients have said this is the first time their kids have been out of the house was for a 2-month, 4-month, 6-month checkup. The Mother's Milk Bank in Mississippi is still accepting donations, and they are still processing donor milk. And I just wanted to touch on that because we do want our moms who may have actually more time to pump to go ahead and continue to make those donations. We are actually having an increasing number of milk donations from approved donors. However, some potential donors have not quite felt comfortable going in for lab work. So we have some donors out there who are still waiting to get their lab work prior to sending in their milk. One last thing I wanted to mention is something that I think is going to be coming out there more and more as we're seeing more and more cases. I had a patient recently who had this scenario. She was 39 weeks pregnant. A friend dropped off a gift and visited with her for about 10 minutes 1 week before delivery. So the friend visited in the house within 6 feet for more than 10 minutes without a mask. A few days after this mom delivered, she found out that this friend tested positive for coronavirus. So this mom was now a contact. The friend was pre-symptomatic when she visited, which means she had no symptoms, but then shortly after she developed symptoms. And we know that even though you're pre-symptomatic, you can be shedding. The friend didn't wear a mask. The mom had to get tested and quarantined from her baby as much as possible, particularly from her other kids, till her test was back. And that was very anxiety inducing for her mom. And I want to say one last thing about pre-symptomatic, asymptomatic. The World Health Organization just came out with some guidelines, and there was some confusion about that. But we absolutely know that people can spread coronavirus when they are pre-symptomatic or asymptomatic. Dr. Dobbs recently just gave us an illustration of a card game where there were 9 people. One person, 2 days later, developed coronavirus. He was asymptomatic during the card game. After that, 8 additional people developed coronavirus. So a card game, an asymptomatic person transmitted it to almost the entire group. So in conclusion, our COVID policies and procedures are continuing to change and evolve as new information is obtained. I would encourage you as hospital, at their hospital, to make sure that those policies are easily visible. Parents are anxious and concerned about themselves and their babies, and we need to really continue to support them with best practices, educate them, and understand those areas that they're dealing with and concerns that they have. COVID disease in babies and children, it is rare, but it can be potentially fatal. We need to make sure we educate moms about the benefits of obviously of breastfeeding and all the skin to skin and those sorts of things, but we need to make sure that's a shared decision-making process. We need to continue with our well baby visits and prioritize them. And a silver lining that I personally have noticed is that many moms have found their hospital experience to be actually more restful, more educational. Their breastfeeding experience may be more successful, more enjoyable. So I think we need to look at those positive aspects as well as we continue to work through coronavirus 19 with newborns and moms. Thank you very much.
Thank you so much for those wonderful presentations. I see there's a lot of activity and questions being asked and answered in the chat. Before we begin with more questions and answers, I just want to make a couple announcements. So the first is that we have a new the Q&A answer base for Cheer that was just launched, and you can find information on that on our social media pages as well as our website. And I will also put it into the chat here so you can find the link. I'll also put the link for where to find this webinar when it is posted online after. And we also have a newsletter that has been going out. And if you are not receiving the newsletter and would like to receive our newsletter, you can also put your email into the chat and we'll be sure to get it out to you. So thank you all so much. And thank you especially to our presenters for those wonderful presentations. And now I'm going to pass it off to Dr. Merwood, who will be moderating some more questions and answers. Thank you.
Hi guys, thank you. That was a wonderful talk to us, both of our speakers. That was great. It's nice to hear new and different voices from, it's great to have both of you on and from Mississippi. So thank you. The chat has been quite busy, but our speakers who pre-recorded those presentations were able to address a lot of the questions in the chat. If anyone has a question that they would like to ask directly, please feel free to unmute yourself and ask it. I will just sort of summarize what's being talked about in the chat here. There's quite a bit of chat about whether telemedicine would continue or not. It has been there has been funding provided for that, but that from the insurance companies, but it hasn't necessarily been guaranteed beyond COVID. So some places like Medicaid is still paying, but only until the 1st of July. So that's kind of an interesting ongoing debate. And in fact, in a couple of weeks from now, we'll have a webinar here with that's sharing all sorts of new experiences and things that have been learned from COVID. And I think certainly we've learned a lot about telemedicine, for better or for worse. Some of us as patients may prefer it, but as has also been noted in the chat, people do miss things. So the doctors may miss things if they're not in person. So there has to be some kind of a balance. I'm just scrolling through the chat here. It seems like the doctors online prefer in person over telehealth, but some of the patients really like the telehealth. So there's definitely going to be a balance. Do people have questions that they would like to either chat in or ask at this point, or anything that was not addressed in the chat? If you would like to re-ask it. I know that our speakers can only stay on until the top of the hour. So if anyone has anything they'd like to ask them, please feel free. I'll stop speaking so that if anyone has anything they want to speak about, they can unmute and ask it.
Hey, Anne, this is Michelle Owens, and I just wanted to let you know that I have a little bit more time. So if
oh, great, okay.
if we need to stay on for a little while longer, I actually do have a bit of flexibility to be able to do that.
Great, thank you. I know, Anita, Dr. Henderson, you definitely have to get off. Is there anything you would like to say now that you're live here and having seen all the things that have appeared in the chat?
Yes, thank you so much. I appreciated hearing Dr. Owens' speech as well. Again, the telemedicine is an interesting thing with kids. It's a little trickier with children compared to adults. Sometimes we have to chase our children around the room to actually get a good view of them, so it can be challenging. However, I will say mental health visits via telemedicine are great for some of our older kids and our older teenagers. So the mental health aspect of telemedicine visits has worked out really, really well. It's going to be interesting to see what happens over the next few weeks with the various insurance providers and Medicaid. As I mentioned, they are only paying through July 1st here in the state of Mississippi. Each Medicaid office in each state gets to make its own rules. So each state has different Medicaid policies. So I think it'll be interesting to see what happens after July 1st here in Mississippi in terms of telemedicine.
Thank you. That's cool. It would be an amazing study to look at what telemedicine's costing for places like Medicaid, because I can imagine that one could work out a solution where certain visits are done by telehealth to everyone's advantage, and you might even get less missed visits because people don't have to they don't have to come in, and then I can imagine certain ones would be required to be in person, and maybe even the reimbursement could be adjusted to the type of visit that's being done.
Well, and I think that's a really good point. I'm sorry, this is Michelle.
Go ahead.
I just wanted to piggyback on that since we're still talking about it. So I think that there are some positives about compliance and those kinds of things that would be increased. And some people might say, oh, well, more visits, then that costs more money. But there's a unique situation in Mississippi specifically, and also in other similar rural and poorer states, where it's a bit of a challenge because the care for these patients we are not an expanded Medicaid state, first of all, but there are other burdens that are shouldered by the healthcare system. For example, 65% roughly of our deliveries are covered by Medicaid. So that lets you know like the numbers of people who depend on that for their care, moms and babies. And then the other part is that there are other issues like transportation and things of that nature. We are the lone academic health center within our state, and though our population is small, just under 3 million people, there are patients who, because of access to specialists and other things, need to come here or close to us in order to be able to get the care that they need. And so many of them have to come 2, and in some instances 3 hours just to get care, and that's routine obstetrical care or access to subspecialty care. And so for those people, Medicaid will also provide transportation, which is an additional cost. So there are some other healthcare costs or expenditures that are covered by Medicaid to help bridge those gaps that a lot of times when we're talking about healthcare delivery, those get lost in the conversation because people don't think about those. But something as simple as Miss Jones, who needs to get, from 2.5 hours away from Dr. Owens to Dr. Owens for her appointment, that's a 2.5 hour drive down here and a 2.5 hour drive back. And that was before before oil was $5 a barrel. So like those kinds of costs also add up. And so a lot of those dollars are being spent on some things that are other than direct patient care. And telehealth can also help to alleviate some of that financial stress. So it's really more about a balance, because it's almost like being on a seesaw. You have the medical costs, but then you have some of the other costs that also have to be countered, that along with medications and other things. But I think that it's spot on. I was the person who says that, yeah, I'd like to see my people in person. And that's just because there are a lot of other issues that my patients in particular struggle with. And when I can lay my eyes on them, a lot of times it helps me to get more to the heart of the problem. And a lot of times it's not really a pregnancy issue, but it might be something else that's affecting them or their compliance that we can get more to the heart of when they are in a room with me with the door shut. So they don't always have the opportunity to do that when it's by telehealth or if it's not direct face-to-face care.
All very, very, very cool comments and thoughts. Yes. Thank you, Dr. Owens. I do. So we have quite a few WIC peer counsellors on, because we work with the community in Mississippi as well. And Brittany, I believe, is at WIC, and she has made a note here that she finds that with WIC they're getting less missed visits than with them when people come into the clinics out in the counties. And I've heard that also from some of the support groups, that the support groups like the baby cafes are getting more attendees as virtual. So definitely there's some pluses and minuses. Shavonda Quinn asked if we're recommending for mothers to breastfeed with a mask on. I think the guidance for people who are positive with COVID or are under investigation for COVID is that yes, you should wear a mask when you feed your baby and when you're working, handling a baby in general. It's not just because of feeding, it's just in general. Masks can prevent you transmitting infections to others. So I would say that the current guidance is that if somebody has COVID or is under investigation for it, yes, they should be wearing a mask. And of course, so should anyone else that is in the family that's exposed to the baby that has not all the time for every single patient, but anyone that's under investigation for COVID or being exposed to COVID. The mask prevents transmission. So in any of those not clear situations, yes, a mask should be worn in the family if the baby's there. I mean, that would be the logical deduction from the recommendations that are out there. Any other questions or comments from anybody? As Maternal mentioned, we do have a real good Q&A forum. And we've taken it's a new forum. You can go in there, ask a question of the CHAMPS team, and we will either answer it ourselves or find an expert to answer it for you or give you the citation. I think one of the things that got touched on very briefly in this call was the different medications and whether or not they're contraindicated in pregnant or breastfeeding women. And I think that is something actually that we will go and look up on LactMed, the reliable source that we all use, and put that online, because we don't need to get into here. I know nobody can make recommendations off the top of their head, but I think we'll just pop the names of some of those drugs onto the Q&A forum so that you guys have easy access to them. That's the answerbase.com that you can see in the chat there. Any other questions? The CHAMPS team can stay on for a bit longer if people have general questions that they want to ask. I do want to reiterate that was a great presentation from both of you, and then really sort of pertinent as we kind of dig in for this COVID, which, you know, wasn't just coming and going and now it's all gone away again. It's a sort of ongoing presence in all of our lives for some time to come. So it's good to have these kind of ongoing strategies for its management. Okay. And thank you for our speakers. If nobody has any questions, I don't know if Maternal or anyone else from the CHAMPS team has anything else they want to wrap up with. No? Okay, well, thank you all for coming. Thanks for your attendance. We have a webinar next week which will include narratives from women who've gone through the COVID experience during their birthing experience. So we look forward to you, and we're still looking for contributors to that webinar if anyone is interested in speaking up. Okay, thank you all very much for coming from Italy, Mississippi, Navajo land, and all the other places that I can see people from. Thank you for coming, and we will be in touch again soon. Bye-bye.